Hi, today we're going to talk about newborn complications. All right, first we're going to talk about neonatal substance abuse. This can happen during pregnancy if a woman is exposed to alcohol or drugs, and the uterine drug exposure can cause anomalies or neural behavior changes. A lot of these behaviors depend, or issues that depend on the specific drug or combination drugs used, the dosage, the route of administration, metabolism and excretion by the mother and the fetus. And again, the timing of exposure and the length of exposure, especially if it's in that first 8 weeks, is really crucial. Substance withdrawal as a newborn occurs when the mother uses drugs that have addictive properties during pregnancy. This includes illegal drugs, alcohol, tobacco, and prescription medications. One of the common things that can happen is fetal alcohol syndrome, which results from the chronic or periodic intake of alcohol during pregnancy. This is tetragonic, so that the daily intake of alcohol increases the risk of fetal alcohol syndrome, and newborns who have fetal alcohol syndrome are at risk for specific congenital physical defects and long-term complications. So this is important to know, and this is something that they do ask in ATI, so I advise you to really look at this. So monitor the neonatal for abstinence with syndrome. So this is withdrawal syndrome that they have, and increases wakefulness using the neonatal abstinence scoring system that assesses for and scores the following. So they're looking at three components: the CNS, the metabolic, vasomotor, and respiratory findings, and then the GI. So for the CNS, central nervous system, they're looking at high-pitched, shrill cry. I mean, they're screamers. They have this incessant crying, irritability. They have tremors, hyperactivity with increased motor reflex, increased deep tendon reflexes, increased muscle tone. These kids have disturbed sleep patterns, their hypertonicity, and they may experience some convulsions. For the metabolic, vasomotor, and respiratory findings, they have nasal congestion with flaring. They have frequent yawning, skin modeling. They have retractions. They have apnea, tachypnea, and greater than 60 breaths per minute. And they are usually sweating, and their temperature is about 99 Fahrenheit. These kids are also tend to have a tendency to sneeze a lot. There's not really cause of why, but they happen to sneeze a whole bunch of times. Their GI, can be poor feeders, just because they're so irritable and sometimes just so active that it's really hard for them to concentrate on feeding. They have regurgitate a lot. Sometimes they have a lot of projectile vomiting, diarrhea, excessive, uncoordinated, constant sucking. So you have some that have opioid withdrawals will have manifestations of neonatal abstinence syndrome. Heroin withdrawal, usually these babies will have a low birth weight. They're small for gestational age, manifestations of neonatal abstinence syndrome, and they have increased risk of sudden infant death syndrome. When they're methadone withdrawal, manifestations again are of neonatal abstinence syndrome, increased incidence of seizures, sleep patterns, disturbances, higher birth weights, and they're compared to heroin exposure. And then if you have marijuana, they are risk for preterm and meconium staining. So some of the blood tests should be done to differentiate between neonatal drug withdrawal and central nervous system disorders. So they will do a CBC, blood glucose, electrolyte imbalance, thyroid stimulating hormone, thyroxine, trirothyronine, drug screens of urine or meconium to reveal the substance used by the mother, and they may do a hair analysis. So your nursing care will be perform ongoing assessment of the newborn using the neonatal abstinence scoring system. Assessment as prescribed, elicit and assess the newborn reflexes. You want to monitor the newborn's ability to feed and digest intake.
It's 7
and
o'clock.
administer frequent, frequent feedings. Swaddle the newborn with leg reflexes. Offer non-nutritive sucking, so giving them like a pacifier can kind of help because they're constantly need to suck on. Monitor the newborn's fluid and electrolytes with skin turgor, their mucous membranes, fontanelles, daily weights, and INO. And then reduce environmental stimuli to decrease lights, lower noise level. So medications are really based on the withdrawal symptoms. Sometimes they may give the baby morphine sulfate, which is an opioid, phenobarbital. Sometimes it's an anticonvulsant. And then it's intended to decrease the central nervous system irritability and control seizures for newborns who have alcohol or opioid withdrawal. So again, we want to assess IV site frequently. If you're giving phenobarbital, check for any medication incompatibilities, decreased environmental stimuli. You want to cluster care to minimize stimulation because again, you want to reduce as much stimulation because the kids can become very, very irritated. Swaddle the newborn again to reduce stimulation and protect the skin from abrasions because they're constantly moving. Monitor and maintain fluid electrolytes. You want to administer frequent small feedings of high-calorie formula, can require gavage feedings. Elevate the newborn's head during and following feedings and burp because you want to reduce the risk of vomiting and aspiration. Sometimes we have to try various nipples to compensate for a poor suck reflex. Have suction available to reduce the risk for aspiration. For newborns who are withdrawing from cocaine, you want to avoid eye contact and use vertical rocking and a pacifier. That seems to kind of help soothe them more. Prevent infection and initiate a consult with Child Protective Services and consult lactation service to evaluate whether breastfeeding is desired or contraindicated to avoid passing narcotics and breast milk. Methadone is not contraindicated during breastfeeding. All right, we're going to shift gears and talk about cardiovascular system defects. The only ones that they mention in this chapter is patent ductus arteriosus and the tetralogy of Fallot and atrial septal defect. The atrial septal defect is a hole in the septum between the right and the left atrium that results in increased pulmonary blood flow, left and right shunt. Usually with this one you hear a loud, harsh murmur with fixed split second heart sound. Sometimes this can lead to heart failure or it could be asymptomatic. You have patent ductus arteriosus is a condition in which the normal fetal circulation conduit between the pulmonary artery and the aorta fails to close and results in increased pulmonary blood flow. The manifestations are murmur, you hear like a machine hum. They had wide pulse pressure and they're bounding pulses, and they also may be asymptomatic and can lead to heart failure. This one's usually one that you hear kind of often is a tetralogy of Fallot, which is a grouping of 4 heart defects, which is fairly common. They have pulmonary stenosis, they have ventricular septal defect, overriding aorta, and right ventricular defect. So what happens with these babies, they become very cyanotic at birth. They're progressive cyanosis of the first year of life, and they have a systolic murmur, episodes of acute cyanosis and hypoxia, and they have a severity of symptoms, conditional TET spells or blue spells. So the TET spells or blue spells occurs in the first 2 years of life. So what happens is that there's a spontaneous cyanosis or respiratory distress or weakness and syncope occur. So usually this is exhibited with crying or feeding. It can last up to a few hours and are followed by a lethargic and sleep. So one of the things that can help relieve the TET spell is when they put the baby in a knee to chest or a squatting position when this happens, so that what happens is that it actually increases the blood flow to the heart so that it can help reduce the cyanosis occurrence that they're having. So risk factors for congenital heart defects is usually related to maternal alcoholism, maternal irradiation, drugs used during pregnancy, maternal malnutrition, maternal diabetes or maternal rubella or something that's hereditary, or advanced maternal age, anything after 40. So there are significant advances in medical technology, surgery as soon as possible. If there's early diagnosis and correction, repair may avoid CHF, congested heart failure. So again, I talked about this in class yesterday, the critical congenital heart screening before discharge. If a child has, and hopefully that can detect it early on, but if a child has congested heart failure, treatment is imperative, sorry. So care at home before surgery, allow as normal as possible, and then routine visits to the clinic and the physician office become a way of life, just because they continue to monitor the baby. All right, just a couple things, just the refreshers. Hepatitis B, if the mother is active or is a carrier, the baby must get hepatitis B vaccine, but they also need to get the HBIG immune globulin, which is immediately after birth, along with the bath to reduced transfer. So these patients should have no forceps, no vacuum delivery is preferred for these individuals. We don't want to break the skin of the newborn because that can potentially expose them. For HIV mother, baby must be bathed after delivery to remove secretions and blood. They want to administer retrovir to the infant after delivery and for 6 weeks following birth. Breastfeeding is contraindicated for these patients, and you want to refer these patients to a provider who specializes in HIV, and they're going to continue to check the baby to make sure that there has been no transmission to the baby. So let's talk about jaundice, which is hyperbilirubinemia. I kind of talked about this briefly in class. So there's a hepatic adaptation. The liver is immature at birth. So infants have high circulation red blood cells due to shortened lifespan. And so what they have is two different types of bilirubin. There's conjugated, which are water soluble, and they break down and they're excreted into the feces. Then you have unconjugated, which are fat soluble that enter in the cells causing jaundice. So what happens is that we want these unconjugated to be eventually broken down to be conjugated and then excreted out. But what happens is that these actually remain, they kind of build up in the body because the baby can't process them. Their liver is immature and it can't metabolize them so fast enough. So, we encourage the babies to eat right after they're born so that they can excrete this out. But some babies just can't because they have a high number. So usually after 24 hours, we do a blood draw. It's required to check their bilirubin levels. And so we have a certain kind of billy tool that we use so that it actually, it's like a little algorithm that a little plug-in that you put the levels and in how many, at what hours. Usually after 24 hours, you take that, and then it'll give you a blood level value, and it'll tell you whether the baby's high risk, low risk, and then at that point, we would notify the doctor, and then they would have to determine what they like to do. So usually what happens is that if it's too high, then they will end up having to be on phototherapy. And what phototherapy does, it actually causes those unconjugated bilirubins to the light breaks it down so that it can be excreted into water soluble and so that it can be excreted into their poo-poos. But they will, depending on how severe it is, it depends if they have like double therapy or single therapy, how many lights they get and how long they get it. But the biggest problem with this is that if these stay unconjugated, they're just kind of floating in their body, and that's how they kind of go to the skin, and that's what makes them yellow. But it actually can cross the blood-brain barrier, and if they have excess bilirubin, it can stain the neurons, it can cause brain damage, it can be irreversible injury, and it can cause epilepsy, cerebral palsy, or mental retardation. So like I said, it's mandatory that after 24 hours that we do that testing, and then if it needs further testing, then they would have to, the doctor will make that call, and then they'll put the baby on those lights. So you'll normally see a yellow or orange skin. They're lethargic, they're hypotonic, poor suck reflex, they have increased sleepiness, high-pitched cry, and fever. So again, this phototherapy uses a light to help reduce the bilirubin lights. It converts fat soluble and conjugated bilirubin, which cannot expel body to water soluble, and then they secrete it in their GI tract. So again, one of the interventions that we need to make sure that when we put them on the Billy lights, that they're in a little isolette, which is that little kind of like that enclosed crib that they had there. So the light's right above it. They should never be too close. That maybe burn the baby too far, may not be effective. Usually they have its housing where it goes into. But you place the baby only in the diaper. You want to expose the entire skin except for the diaper area. And then you have to make sure that you turn the baby every 2 hours to expose the skin evenly. So just think of them like little roasted chickens. You have to shield the baby's eye from UV light. That's very important, that you have to shield their eyes, because that can potentially damage their eyes. So they monitor bilirubin levels, report pediatrician. They also have a Billy blanket. So these are more for low risk, that they have. It's still elevated, but not, extremely where they need to have double therapy. but these allow them to be in the room with the mom and carry the baby. So that's always optional if the institution has it. If the levels normal, they usually can return home. Otherwise, remain high, may have to stay until the levels decrease. So this is a great video that I highly recommend that you watch when you get a chance, and it talks about jaundice as well. So again, you want to observe for side effects of phototherapy, maculopapular skin rashes or papules, bumps and macules. There's check for pressure areas. That's why you should be turning every 2 hours. Make sure they're not becoming too dehydrated because it's going to help them excrete in their feces. So looking out for poor skin turgor, dry mucous membrane, decreased output, elevated temperature or depressed fontanelles. You want to feed every 3 to 4 hours to promote bilirubin excretion in stools. The other thing is bladder exstrophy, which is eversion of the posterior bladder through the anterior bladder wall and lower abdominal wall. These baby have epispadias present. Remember when I told you where the meatus is not located in the center of the penis, at the tip of the penis. This one is actually, I have to say if it's on the top side of the penis, just double check. I'm pretty sure that's it, but I just can't think off the top of my head right now. So diagnostic, you want to do a fetal sonogram. Treatment and nursing care, cover exposed bladder with sterile non-adherent dressing. And then prepare for immediate surgery for this because they need to correct this because they can't have this bladder sticking out. So that's why you have to maintain it nice and moist so that it doesn't dry up. Sometimes we will have a baby that has a cleft lip. And so basically that's a fissure or opening in the upper lip, failure of the maxillary and the medial nasal process to unite during embryonic development. This may be hereditary or it can be environmental. It occurs more often in boys than girls. The initial repair of the cleft lip is known as chyloplasty. It repairs by 3 months of age. Infants may have to use elbow restraints to prevent them from scratching the lip. They usually have to have a special syringe or a bottle and may need it to assist in feeding until the child has surgery. So once they get the operation to correct this, they usually have to prevent the infant from sucking and crying. So careful positioning to avoid injury to operative site. Preventing infection and scarring by gentle cleansing of the suture lines to prevent crust from forming. Again, you want to provide infants' emotional needs by cuddling and other forms of affection and provide pain relief. Sometimes they'll be fed by a drop until wound is completely healed about 1 to 2 weeks, and cleanse the mouth by giving the infant small amounts of sterile water at each feeding session. So sometimes you have the cleft palate, which is the failure of the hard palate to fuse at the midline during week 7 to 12 weeks of gestation. And this can form at the passageway between the nasopharynx and the nose and increase risk of infection in the respiratory tract and middle ears. So again, the nutrition is progressively advanced, so no foods through straws to prevent sucking. Follow each feeding with a clear water to cleanse the mouth. You want to encourage children to pronounce words correctly. Sometimes they will have to have a speech therapist, get evaluated because they may have some issues with speaking. Diversional crying should be avoided whenever possible. Play should be covering, drawing, reading to the child. And then, these kids are at risk for ear infections as well and tooth decay. We talked about, in pregnancy, one of the things that we want to prevent is spina bifida, and we have our women take 400 micrograms of folic acid, and we also tell them to eat foods, fortified folic acid foods, so that it can prevent neuro-2 defects. And so what happens is a group of central nervous system disorders characterized by malformation of the spinal cord. So it's a congenital embryonic neuro-tube defect with an imperfected closure of the spinal vertebra. So you have 2 types. You have occulta, which is hidden. You have cystica, which is a sac or a cyst. Then you have meningocele and myelomeningocele. So usually what you see at diagnostic testing is an elevated maternal alpha fetoprotein level. Testing is typical. They have an ultrasound of the fetus, and best time to perform these tests is 13 to 15 weeks gestation when peak levels are reached, and may include a magnetic resonance and imaging MRI or ultrasonography. So for the spina bifida occulta, this is variation of the disorder. Its opening is very small. It's not associated with protrusion or any structures. It's often undetected. But you may see this tuft of hair or the dimpling. Remember I had mentioned in the newborn assessment, or they have or discoloration at the site. So usually they're not necessary unless neuromuscular symptoms appear. So usually they can do okay for the most part, but what they want to be looking out for is progressive disturbances of gait or foot drop, or disturbances of bowel and bladder sphincter function. You have spina bifida cystica, development of a cystic mass in the midline of the opening in the spine, meningocele or meningomyelocele. Meningocele contains portions of membranes and CSF. Size varies. If no weakness of the legs or sphincter involvement, surgical correction is performed with excellent results. You have the meningomyelocele, more serious protrusion of membranes and spinal cord through the opening. May have associated paralysis of lower extremities, may have poor or no control of bladder or bowel. Hydrocephalus is a common complication. Surgical intervention is done for cosmetic reasons and to help prevent infection. And then you have habilitation is usually necessary post-operatively because the legs remain paralyzed and the patient is incontinent or urine and feces. All right, so the treatment is usually a surgical closure. There's prognosis dependent on extent of spinal cord involvement. So upon delivery, the newborn is placed in an incubator. Moist sterile dressing or saline or antibiotic solution may be ordered to prevent drying of the sac. Protection from injury and maintenance of a sterile environment for the open lesions are essential. Prevent infection or injury to the sac. You want to correct positioning to prevent pressure on sac, prevent development of contractures, good skin care, adequate nutrition, size and area of sacs are checked for any tears or leakage. Extremities are observed for deformities and movement, and accurate observation and charting. So education of the parents as well. So this is very important to listen to them, and especially because their child is going through this, and it may be really, really difficult to go through. Okay, so then we have congenital complications, preterm birth. So you're going to see a lot of this in probably just in general. We talk about preterm birth because it's very, we have a high rate of that, and there are really vulnerable babies. So I would review this for ATI as well because they do ask questions on this. It is a cause of more deaths during the first year of life than any other single factor. There are a higher percentage of high birth defects. The less the preterm weight at birth, the greater the risk to life during delivery and immediately thereafter. Actual time from conception to birth that the fetus remains in the uterus. So we want them to remain as long as they can. Preterm infant is anything less than 37 weeks. So contributing factors can be multiple birth, maternal illness, hazards of actual pregnancy, placental abnormalities, either placenta previa, premature separation of the placental from uterine wall. So physical characteristics of preterm infant. Skin can be very transparent or loose. They have superficial vein visible on the abdomen and scalp. Lack of subcutaneous fat. They'll have lanugo covering forehead, shoulders, and arms. Vernix gaseosa abundant. Extremities appear short. They have soles of feet have a few creases. Abdomen protrudes. Nails are short. Genitalia are small. In girls, the labia majora may be open or absent. So they have inadequate function. They risk for respiratory distress syndrome. They can have apnea or neonatal hypoxia. They can experience sepsis or poor control of body temperature. They become very hypoglycemic, or they can have hypocalcemia, increased tendency to bleed. Retinopathy of prematurity, kind of affects their eyes. Poor nutrition, necrotizing enterocolitis, which affects their GI system. They have immature kidneys and jaundice, you name it, they have it all pretty much. So we'll kind of go into the differences. So inadequate respiratory function, so during second half of pregnancy, They'll have structural changes occur in the fetal lungs. So the alveoli will enlarge. They have closer to capillaries in the lungs. And then they have failure of this phenomenon leads to many deaths. If born prematurely, the muscles that move the chest are not fully developed, and their abdomen is distended, increasing pressure on the diaphragm. So stimulation of the respiratory center in the brain is immature. Gag and cough reflexes are supplied due to immature nerve supply. So respiratory distress syndrome results of immature lungs, leads to decreased gas exchange. If infant is premature, the surfactant level is insufficient. Can take up to several hours after birth to be manifested. Respiration decreased to 60 breaths per minute or higher. They have tachypnea. The tachypnea may be accompanied by grunt-like sounds, nasal flaring, cyanosis, as well as intercostal and sternal retractions. And edema, lassitude, and apnea occur as the condition worsens. Mechanical ventilation may be necessary. Careful monitoring O2 levels for toxicity. So bronchopulmonary dysplasia, the toxic response of lungs to oxygen therapy. The risk is atelectasis, edema, thickening of membranes, interferes with ventilation, often a result of prolonged dependence on supplemental oxygen and ventilators, and they can have long-term complications. They also have poor nutrition, so their stomach capacity is very small. Sphincters at either end of stomach are immature, so they have increased risk of regurgitation and vomiting, and they have sucking and swallowing reflex are very immature. So their ability to absorb fat is very, very poor. They have increased need for glucose and other nutrients to promote growth and prevent brain damage are contributing factors. So they have parental or gavage feedings may be needed until infant systems are more mature. And they use that pacifier to provide nutritive suckling with gavage feeding. So these babies, need a lot of extra help. A lot of the recommendations to give babies breast milk because it does have, it actually helps them promote growth. So we encourage the moms to pump and bring milk to the NICU if they are admitted still in NICU, because that really does help with the babies in growth and development. Poor control of body temperature. Since we kind of talked about thermoregulation, they have that lack of that brown fat, which is their body's own insulation. So the radiation from a surface area that is large in proportion to body weight. They have the heat regulating center of brain is immature. Their sweat glands are not functioning to capacity. Preterm is inactive, has muscles that are weak, less resistant to cold, unable to shiver. Preterm body position is one of leg extension, a high metabolism prone to low blood glucose levels, and can result in cold stress, increased need of oxygen and glucose. Signs and symptoms of cold stress: decreased temperature, increased respiration rate, bradycardia, modeling of skin, and they can be lethargic. So again, glucose levels less than 40 in a term preterm, and in babies, preterm babies, it's less than 30. It's like hypoglycemic. So they have not remained in utero long enough to build up stores of glycogen and fat. They're aggravated by increased need of glycogen in their brain, heart, and other tissues. So any condition that increases metabolism increases glucose needs. So energy requirement places more stress than they're already with their deficient stores. So there's a lot going on with these babies. So they have neonatal hypoxia, which is inadequate oxygenation at the cellular level. You have degree can be measured via pulse ox, and you have oxygen and hemoglobin in circulating blood divided by oxygen capacity. So their saturation levels are about 92 or above is normal for them. These kids are very vulnerable, so they're at risk for sepsis, so generalized infection of the bloodstream, so they're at risk due to immaturity or many body systems. Liver is immature, poor formation of antibodies, and poor body enzymes are inefficient. Necrotizing enterocolitis is acute inflammation of the bowel that leads to bowel necrosis. Factors include diminished blood supply to bowel lining, leads to hypoxia or sepsis, causing a decrease in protective mucus, results in bacterial invasion. The source of bacterial growth if receiving milk, formula, or hypotonic gavage feedings. So increased tendency to bleed. So blood is deficient in prothrombin. Fragile capillaries of the head are susceptible to injury during birth, which can lead to intracranial hemorrhage. So we have retinopathy of prematurity, which is a separation and fibrosis of retina, which can lead to blindness. Damage to mature retinal blood vessels thought to be caused by high oxygen levels in arterial blood. The leading cause of blindness in infants weighing less than 1,500 grams. So they cannot eliminate body waste effectively, contribute to electrolyte imbalance, and disturb acid-base relationships. Dehydration occurs easily with these babies, and tolerance to salt is limited, and they're susceptible to edema is increased. So they have immature liver, contributes to conditions like icterus. Nursing goals for preterm newborns. So again, we want to improve respiration, maintain body heat, conserve energy, prevent infection, provide proper nutrition and hydration, give good skin care, observe infant carefully, and record observations, promote growth and development, and support and encourage the parents. So beyond preterm newborn, these are babies that are born after 42 weeks gestation. Placenta does not function well after a certain point, can result in fetal distress, and their mortality rate is, in later terms, infant is higher than that of a term newborn. So their morbidity rates are also higher. So problem that that they can have is asphyxia, meconium aspirations. They can have poor nutritional status, increase in red blood cells production, difficult delivery due to increased size of fetus, birth defects, and seizures. So these babies, when we were talking about the Ballard scale, these babies can be long and thin. Weight may have been lost. Because remember, the placenta has a term date, so they can't be in there that long, and so it's not working as efficiently. So these babies' skin is loose, especially around buttocks and thighs. Little lanugo or vernix seosa starts to peel off. Their skin is dry, cracked, and peels. Nails are long and may be stained from meconium, and the thick head or hair and they're very alert. So again, you want to be careful with these babies. You want to be looking out for respiratory distress, hypoglycemia, hyperbilirubinemia, and cold stress. So you can have babies that are also small for gestational age. These are babies that are less than 10% percentile who have intrauterine growth restriction. So their common complications of newborns are SGR or perinatal asphyxia, meconium aspiration, hypoglycemia, polycythemia, and instability of body temperature. So the risk factors can be due to congenital chromosomal abnormalities, gestational hypertension, maternal smoking, alcohol use, multiple gestation, placental factors, decreased placental perfusion, fetal congenital infections such as rubella or toxoplasmosis. So again, these babies are small. They have normal head but reduced body dimension. Their hair is sparse on the scalp. They have wide skull sutures from adequate bone growth, dry, loose skin. They have decreased subcutaneous fat. They have decreased muscle mass, particularly over the cheeks and buttocks. They're very thin, dry, yellow, and dull umbilical cord rather than gray, glistening, and moist. Drawn above abdomen rather than well-rounded. Respiratory distress and hypoxia. They're wide-eyed and alert, was attributed to prolonged fetal hypoxia. They have hypotonia, evidence of meconium aspiration, and they can be very hypoglycemic. The large babies, these are usually those babies that are macroscomic, I can't even say it right now. Macrosomic describe babies whose birth weight is above 90 percentile or more than 4,000 grams. The LGA are at risk for birth injuries, especially like shoulder dystocia, clavicle fracture, or cesarean birth, or asphyxia, or hypoglycemia, or polycythemia, and Duchenne's paralysis due to birth trauma. Manifestations are way over 4,000 grams, the plump and full face, hypoxia, tachypnea, they have retractions, cyanosis, sometimes nasal flare and grunting, and birth trauma, and sluggish hypotonic muscle hypoactivity. We'll talk about phenylketonuria. This is a faulty metabolism of phenylalanine, an amino acid essential to life and found in all protein foods. The infant is unable to digest this essential acidic, and phenylene accumulates in blood and is found in the urine within the first weeks of life. This actually results in severe mental retardation if it's not caught early, so that's why they have to do those metabolic screenings after 24 hours so that they can detect this. These babies will manifest frequent vomiting, aggressive, and hypoactive traits. So for this, you need to, blood tests should be obtained 48 to 72 hours after birth, preferably after the infant has ingested proteins. Many states require the test to be performed prior to discharge. Delayed development apparent at 4 to 6 months, may have failure to thrive, eczema, or other conditions. Child has a musty odor. They may have personality disorder. They occur mainly in blonde, blue-eyed children, and results from a lack of tyrosine needed for melanin formation. So this synthetic food that provides enough protein or growth and tissue repair. So they have to have a special formula for these children. And you definitely need to review for mothers what are their nutrition that they should eat as adults if they have this. And that was more back in the prenatal, so I would review that. Go back to review that for ATI. Fetal alcohol syndrome. So I kind of briefly talked about this, but in the first slides. So this usually for these children have hypoactivity. This is when they're exposed to alcohol, and again, that's why we tell mothers that, no alcohol is safe, no any amount. So, because babies can develop this. These babies may have tremors, low birth weight. They usually have a distinct look. So they have like a small head. They have shortened eyelids, flattened nasal bridge, and brain damage occur during pregnancy. So again, these babies are need to be swaddled, decreased sensory stimulation. So you want to have a quiet room and dark. Provide adequate nutrition and daily weights to these babies. Eat. Sorry, it just kind of stopped right now. Let me go back. Sorry. We're almost done. Oh, that is it. I'm sorry. That concludes our lecture. So the next lecture I would do is breastfeeding is what concludes.